So it's a great pleasure to be here today, and thank you, Ascendi, for this training initiative, because it's very important, not just for you, but also for us to share our experience and also learn more about hypoparathyroidism. So I hope that you enjoy these clinical cases, because now we will talk about the management of hypoparathyroidism. So we thought about present the cases in Portuguese, because maybe it's easier to discuss between everybody, but then the final discussion will be in English, and of course that if any person wants to ask something, we are able to do it at any time, okay? So, começo então com o primeiro caso. Isto vai ser um bocado difícil andar sempre a mudar, mas pronto, acho que sim. Portanto, o meu primeiro caso trata-se de um homem que me vem referenciado à consulta de endocrinologia do hospital aos 50 anos. E, portanto, aquilo que eu tinha de informação é que realmente ele tinha um seguimento irregular de um hipoparatiroidismo que estava documentado perfeitamente, portanto, com uma PTH induziável. E aquilo que ele me conta, quando entrei no gabinete, é que realmente tinha um hipopara, que tinha sido intervencionado, portanto, tinha sido submetida a uma hemitiroidectomia há 5 anos, sem nenhuma malignidade. Tem sido sempre tratado, sempre seguido no privado, portanto era um senhor que apenas tinha consultas no privado, ele não tinha absolutamente quase nenhuma informação em lado nenhum, nem mesmo no médico de família. E aquilo que ele me traz são análises de décadas ou de vários anos, uma grande confusão, com doseamentos de cálcio completamente, portanto, dispares, portanto, alguns bastante baixos, um ou outro até normais ou até um bocadinho acima do normal. E depois, relativamente à medicação, também andava sempre com ajustes, e aquilo que tinha vindo a tomar de forma crónica era a suplementação com carbonato de cálcio, mas com muita intolerância, já tinha experimentado várias formulações, e fazia também uma terapêutica com calcitriol, mas de forma muito intermitente. E, para além disso, quando nós questionamos acerca da história clínica, fala-me de várias comorbilidades, como cataratas, outras doenças oculares, glaucoma, já tinha tido alopécia, tinha uma gastrite crónica que não ajudava à tolerância desta medicação. E, quando eu questiono, então, mas como é que se sente com esta dose, sente parestesias, sente queimbras, como é que é? Ele diz-me que, afinal, até já tem isto desde a infância, que até já tinha estado internado por causa de convulsões várias vezes, a primeira vez aos 7 anos. E eu, então, vamos parar tudo, desde quando é que esta história afinal é? Não era nada desde a cirurgia à tiroide, que era aquilo que até vinha na informação clínica, mas afinal já vinha desde a infância. E depois, basicamente, o que o doente mais queria falar durante aquela consulta era porque, afinal, ele era preocupado porque tinha vindo a perder muito peso, andava muito cansado, que até lhe andavam a perguntar o que é que se passava, porque parecia doente, o que é que se passava com ele. E, pronto, em termos de exame físico, tensões normais baixas, e realmente aquilo que eu mais tinha reparado é que o senhor realmente era bastante moreno, mas até pensei que fosse a cor dele natural, e depois perguntei, afinal não, ele diz mesmo que estava com a cor da pele a escurecer ao longo do tempo, portanto ele tinha uma hiperpigmentação importante, e também reparei que tinha onicomicose tanto nas mãos como nos pés. E vocês acho que já estão a ver onde é que isto tudo vai dar, não é? Portanto, na altura, suspeitei que podia haver algo mais para além daquilo que nós já sabíamos, de uma insuficiência suprarrenal que, entretanto, foi confirmada. A consulta foi de tarde. Ele colheu um cortisol na altura e o cortisol era de 1, acho que era assim uma coisa, durante a tarde. E também tinha, portanto, depois também com a ajuda que eu tive, uma candidíase mucocutânea crónica. E pronto, iniciou então terapêutica de substituição para a suprarrenal e terapêutica antifúngica para esta onicomicose. E eu apresento-vos aqui, no fundo, um resumo de tudo o que ele tinha, porque basicamente, então, temos o hipopara então, aos 7 anos, depois as cataratas detectadas a primeira vez aos 25, a alopécia transitória, depois aos 45, então, a tal hemiteroidectomia, depois ainda foi intervencionada uma colitíase, aos 46, um glaucoma mais tarde, depois uma queratite e a onicomicose desde os 49 anos, e estava ele comigo com o diagnóstico de doença de Addison aos 50 anos. E, portanto, agora vamos iniciar a nossa parte interativa. Portanto, com os vossos telemóveis. Não sei se passa automaticamente ou se eu é que tenho que avançar. Já toda a gente tem? E, portanto, então, questiono-vos com esta apresentação clínica, portanto, com o hipopara, com a doença de Addison, com a candidíase, com as cataratas, a alopécia, a distrofia, portanto, a tal situação fúngica nas unhas, a gastrite crónica. O que é que vocês acham que melhor explica esta situação? Pronto, estou muito feliz, não é? É mesmo isso, cheira logo, não é? Portanto, ele tinha um síndrome poliglandular autoimune do tipo 1, ou pelo menos eu achei que sim, e realmente pedi-lhe o teste genético do GNR, isto foi muito fácil, não precisei de pedir painel nenhum, não é? E realmente veio positivo para uma variante patogénica. Depois questionando, depois não, eu até já tinha questionado em relação ao irmão, ele não tem grande relação com o irmão, portanto, insisti com ele para falar com o irmão, só para lhe informar que tinha esta situação e que ele deveria ir a uma consulta de genética que na altura ele não aceitou, e tem 2 filhas que na altura fizeram doseamento de cálcio que eram perfeitamente normais. E para vos ainda dizer que, passados 5 anos, este doente ainda teve outra infelicidade, que teve, apesar de tudo, o início da diabetes tipo 1, a apresentação não foi dramática, mas teve também, portanto, ele também tem uma diabetes tipo 1. Portanto, e neste momento, a terapêutica habitual dele é calcitriol, 3 comprimidos por dia, carbonato de cálcio, ele tinha grande, como eu vos disse, grande intolerância, portanto, esta é a formulação que ele mais tolera, e está a fazer também 3 comprimidos por dia, a sua levotiroxina, hidrocortisona e fludrocortisona pela insuficiência suprarrenal e a medicação para a diabetes, que aí ele apresenta um ótimo controle da diabetes. Acho que é das poucas coisas que ele está mesmo em pleno, apesar de não ser uma doença fácil, mas a diabetes tipo 1 até está bastante bem controlada. E em relação então à parte do hipopara, trago-vos aqui um ponto da situação numa altura da sua vida, digamos assim, e que no fundo é aquilo que mais tem acontecido com esta terapêutica, ou seja, a minha dificuldade é tê-lo sem sintomas, e consigo tê-lo sem sintomas com um cálcio um bocadinho abaixo do normal, 8,6, mas isto é muito frágil, isto baixando um bocadinho, ele fica logo, e aliás, até faz medicação extra por sua própria iniciativa. Depois um fósforo, que é das minhas maiores dificuldades, que está sempre aumentado e que eu já tentei alterar aqui o calcitriol, mas leva logo uma hipocalcémia. E depois tem outro problema, é que eu não posso aumentar muito o cálcio, porque ele também tem uma hipercalciúria, que neste caso já foi maior e que me dá aqui muita dificuldade em gerir esta medicação. E, portanto, a próxima pergunta. E nós podemos discutir, eu trago-vos o caso e a minha noção do caso, mas se alguém tiver alguma ideia que me ajude, por mim, perfeito. Portanto, próxima pergunta. Então, qual é, em primeiro lugar, o objetivo terapêutico para este doente? Hipótese A, manter o cálcio perfeitamente normal. Hipótese B, normalizar o fósforo, mesmo à custa de haver uma hipercalcémia, manter o cálcio, portanto, abaixo do normal, normal baixo ou abaixo do normal, ou ter como alvo os níveis de magnésio altos. E, obviamente, que é a resposta C, que é manter o cálcio normal baixo, ou abaixo do normal, que é o caso deste doente. Pergunta 3. Portanto, em relação à hiperfosfatemia persistente deste doente, não é? Portanto, sempre bastante acima e que me dá aqui grandes dificuldades, o que é que vocês acham que aqui nós podemos, qual é a estratégia que nós podemos aqui optar? Aumentar o calcitriol? Iniciar uma restrição de fosfato através da alimentação e adicionar um tampão do fósforo, que não seja cálcico, não é? O carbonato de cálcio pode ser um tampão interessante, mas aqui há outra coisa que eu vos falei há bocadinho. Aumentar a suplementação oral de cálcio, eu estou a ajudar a responder na mesma. Ou então parar a suplementação com o colecalciferol. Isto é discutível. Pronto, a B tem mais pessoas a responder e que é também aquela que eu considero correto, embora aqui não seja uma gestão de todo fácil, não é? Porque há muitos alimentos, alguns alimentos que os que têm cálcio também têm fósforo, não é? Portanto, não é fácil fazer uma restrição de fósforo. Claro que o fósforo está presente em alimentos altamente proteicos, na carne, nos produtos lácteos, em alguns cereais, portanto nós podemos, em conservas, e nós podemos aí ver se há algum que ele esteja a ingerir em demasia e que possa haver aqui alguma forma de ajudar. Também é um doente que tem uma diabetes tipo 1 e que também pode optar um bocado pela proteína, portanto aqui a gestão também não é muito fácil. Adicionar um tampão não cálcico é a melhor opção. Aumentar o cálcio é que se calhar não é a melhor opção por causa da hipercalciúria. A não ser que nós consigamos gerir a hipercalciúria. Não sei se está toda a gente de acordo. Próxima pergunta. Então, em relação ao hipoparacrónico, portanto, a esta situação de todo o doente e à hipercalciúria persistente, o que é que nós podemos fazer para diminuir a excreção de cálcio pela urina? Hipótese A, reduzir a suplementação de cálcio, e assim nós conseguimos reduzir, obviamente, a excreção de cálcio pela urina, aumentar a dose de calcitriol, iniciar hidroclorotiazida até esta dose, de 100 mg por dia, ou iniciar indapamida e monitorizar as tensões e os eletrólitos. Pronto, eu trouxe-vos esta pergunta aqui de propósito e que acaba por ter aqui uma rasteirazinha, mas era também para tornar o caso mais didático. Yes. Yes, I appreciate.
I had with the patients with adrenal insufficiency,
yes,
because you use as the treatment fludrocortisone, which is a replacement for aldosterone.
Yes.
And aldosterone, when you have an excess of aldosterone, like in primary aldosteronism, you have a loss of calcium via the urine, via the feces. And the typical sign of patients with primary aldo is that they have secondary hyperpara. So the PTH is usually high or elevated in primary aldo. So when you take care of such a patient with concomitant hypo-PD and adrenal insufficiency, I would also view this patient as someone where I would not like to overdo it with the fludrocortisone supplementation. So maybe keep it as low as possible. You use the renin, you use the potassium, but if you could titrate it down a little bit, the fludrocortisone, this would be good for the calcium balance. And one case I have to share is I had a patient with concomitant hypo-PD and primary aldo. So both diseases. This patient went for surgery for primary aldo. And of course, after surgery for primary aldo, you had a decrease in the aldosterone. And as aldosterone is promoting calcium losses, we could dramatically reduce the active vitamin D treatment in this patient. And if you have such patients, you should anticipate that surgery for primary aldo does have an impact on the requirement for conventional therapy of hypo-PT patients. So this was a learning for me because this patient actually got renal stones after surgery because I was not anticipating this at the time I took care of this patient. So a learning for me, don't make the same mistake.
Okay.
Take care of this and consider a very special situation, but
I really
a learning
appreciate-
as an
but,
endocrinologist for me.
You are suggesting that I reduce the doses of
Yes,
Fludro
if you have this
first?
constellation,
Okay.
if you have this constellation, or at least if you have hypo-PT in primary aldo and you treat primary aldo by surgery, you have to anticipate a reduction in the requirement of conventional therapy because we know that aldosterone is promoting calcium losses.
Okay, I think that I have to take care about his blood pressure because his blood pressure is not so good, and
That's clear.
yeah.
For the
it's a bit-
fludrocortisone replacement therapy, you look at the blood pressure, you look at the potassium, and you look at the renin, as we all do.
But
And
I
if this
can
is required, then
see-
of
okay.
course. But I would try everything to avoid the oversupplementation,
Okay.
overtreatment with fludrocortisone
Okay,
in a
thank you.
patient with Addison's disease and with hypo-PT. I just wanted to
No,
share a
I
little bit
I
of
really
my
appreciate it.
experience
It's a very nice
and of my learning.
because I didn't read or think about that, so it
Yeah.
is very important. Here I wanted to talk about another thing that I think that it is also important, that is hydrochlorothiazide. It's a bit dangerous if we try it without monitoring of blood pressure, because I tried in this patient, but it was not so good. My patient was hypotension because hydrochlorothiazide reduces the volume, the blood volume, and also the sodium, and it is very dangerous when we have a patient with adrenal insufficiency. So we can try another thing that I tried, and now the patient is with this, indapamide, a low dose indapamide, and then we try to see what happens. I don't know yet if it will result or not. It is just a try, because I want to see if I can reduce a bit this, because of the risk of the kidney. Aqui não há respostas corretas ou erradas, como veem, eu própria estou a aprender com as minhas perguntas. I was saying that it is we don't have only correct or bad answers, because I am learning with my own questions. So, pergunta 5. Para terminar, então, o que é que vocês acham, então, que neste doente podemos eventualmente pensar no futuro fazer em relação a todo este quadro, se mantiver, ou tentar de tudo, e se ele mantiver sempre a hipercalciúria persistente e a hiperfosfatemia, não conseguir com o tratamento convencional e com tudo o que eu tenho de alternativa, lidar com isso. Portanto, para além do que tenho feito, se eu tenho que aumentar ainda mais as doses do cálcio e do calcitriol, se eu tenho que adicionar um diurético da ANSA, se eu posso pensar numa terapêutica com PTH, ou se eu tenho que parar o calcitriol para então reduzir os níveis de fosfato. Pronto, esta pergunta é pensar no nosso futuro, não é? Porque eventualmente poderá ser um doente que poderá ser candidato ou não. Vamos ver, esperemos que o futuro nos seja alegre a esta terapêutica.
Sorry, just to ask, so everyone here voted for PTH replacement therapy,
Yes.
right?
Sorry.
Okay, so there's nothing more to say.
I didn't say anything because for me it was obvious. So.
Just a small comment. For this specific patient, we were discussing about keeping calcium levels low normal or just above low normal levels. But in this specific patient, because of his genetic hypoparathyroidism, there is no remnant parathyroid tissue like to stimulate. So it's only about the dynamic balance between hyperphosphatemia,
Yeah, it is because of that, not because of the stimulating PTH, because it doesn't exist.
Trying to keep calcium levels low, of course, always when the patient feels good, because if he doesn't feel good, Yeah.
Yeah.
And I just, you know, I don't know if you noticed, this particular patient is taking 10 pills per day.
It was just
10.
endocrine therapy because he has more.
Yes, of
Yeah.
course, but it's 10.
Yes. And type
So
1
we are talking
diabetes,
about
that
the
is
pill burden here. Yeah.
it is a burden of disease that we can't imagine.
Any questions? Do you have any question?
Para terminar, portanto, quero aqui demonstrar que não esquecer, obviamente nós temos, a maioria dos nossos casos são pós-cirúrgicos, mas não esquecer de tentar rever como é que o diagnóstico foi feito, quando é que os sintomas apareceram, porque não podemos esquecer as causas congénitas e autoimunes. Também, então, termos atenção aos níveis de cálcio, que neste caso, até já tivemos aqui esta explicação, que neste doente até devem estar normais. Aqui nós conseguimos tê-lo um bocadinho abaixo, sem grandes sintomas, mas o objetivo até é que seja normal neste doente. E que realmente tanto a hiperfosfatemia persistente como a hipercalciúria têm que ser abordadas e tentadas ao máximo realmente que sejam solucionadas, e para isso a terapêutica com a PTH pode ser uma solução importante se as outras terapêuticas que nós tivermos não conseguirem solucionar. Any question about this specific case, or we pass to the next one? Okay.
I have one question. So if we didn't know anything about the medical history of these patients, and we don't know that he's post-surgical and he has hypoparathyroidism, we would consider to search for something more, or we could just say, okay, he has post-surgical hypoparathyroidism, we don't need to check anything else.
You are questioning me if I
If you
thought...
don't know anything about what she had before, you didn't know about the medical history.
Levels of PTH are undetectable.
Low PTH level,
are
low
undetectable. So in this case, when I saw it, I thought it was very strange for this patient. So maybe because of that, I don't remember. It was
But on
some
the other
years
hand,
ago.
hypothyroidectomy
Yes,
is not
it is
usually
not because maybe 2 parathyroids. So no.
usually a risk factor
Yeah.
for hypoparathyroidism.
Levels was a good thing to see and think about other etiology.
So you're a good doctor. Yeah. Okay, let's go on to the next one.
So now I'm going to present a clinical case of hypoparathyroidism and bariatric surgery. I'm going to present it in Portuguese, but I definitely will. I'm looking forward for your ideas and your help managing this case. Portanto, apresento-vos o caso de uma doente que foi referenciada no início do ano passado à consulta de endocrinologia, de 43 anos, com um hipotiroidismo e hipoparatiroidismo pós-cirúrgicos. Na recolha da história clínica, ela refere que aos 32 anos, num hospital privado em Lisboa, foi submetida a uma cirurgia de bypass gástrico em Y de Roux por obesidade mórbida. 2 anos mais tarde, também num hospital privado, mas já no Algarve, foi submetida a uma tiroidectomia total por um bócio multinodular que, no exame anatomopatológico da peça cirúrgica, revelou uma patologia benigna. No seguimento da cirurgia, desenvolveu um hipoparatiroidismo pós-cirúrgico, que ela relata que era refratário a doses elevadas de carbonato de cálcio e calcitriol, e que resultou em múltiplas idas a serviço de urgência e até uma hospitalização por hipocalcemia grave. Durante essa hospitalização, ela foi assistida pela equipa cirúrgica e a equipa cirúrgica acabou por decidir reverter o bypass gástrico, e ela refere ainda que até esse procedimento ser realizado, ela precisou de infusões de cálcio intravenoso semanais. Após a reversão do bypass, o controle da calcémia melhorou. No entanto, a doente mantinha queixas significativas de cansaço, queimbras, parestesias periorais e distais, e isso ela referia um grande impacto nas atividades de vida diárias. Além disso, nas outras comorbilidades, destacava-se um diagnóstico de fibromialgia e síndrome depressivo. Portanto, ela vinha medicada, ela estava a ser assistida numa consulta de medicina interna, também no mesmo hospital privado onde foi submetida à tiroidectomia total, e ela vinha medicada com carbonato de cálcio, numa dose equivalente a 500 mg de cálcio elementar, estava a tomar 2 comprimidos 3 vezes por dia, portanto numa dose total de 3.000 mg por dia. Para além disso, estava medicada com calcitriol, numa dose total de 0,75 microgramas por dia, repartida por 3 cápsulas por dia. Vinha ainda medicada com clortalidona, 12,5 miligramas por dia, e isto envolvia a necessidade dela fazer um suplemento de potássio. Para além disso, tinha outras suplementações, incluindo colcalciferol, 25 mil unidades por mês. E trazia os seguintes resultados analíticos. Tinha um cálcio de 6,7, um fosfato de 4,7, uma 25-hidroxivitamina D de 27, o magnésio estava dentro da referência, mas junto ao limite inferior do normal, tinha uma hipocaliémia e tinha uma TSH mal controlada. Portanto, o que é que fariam seguidamente? Portanto, podíamos aumentar a dose do calcitriol, a hipótese A seria aumentar a dose de calcitriol e carbonato de cálcio, a hipótese B seria substituir o calcitriol por alfa-calcidol, a hipótese C seria substituir o carbonato de cálcio por citrato de cálcio, a hipótese D seria descontinuar o diurético e a hipótese E seria iniciar o tratamento com PTH recombinante. Ok? Infelizmente, em Portugal não temos ainda forma de substituir a PTH através de um fármaco recombinante, excepto através de um medicamento em utilização off-the-label. Substituir o calcitriol por alfa-calcidol não fazia sentido, porque o calcitriol é 2 vezes mais potente que o alfa-calcidol, portanto seria uma sobrecarga ainda maior nos comprimidos que a doente tomava, e realmente propusemos descontinuar o diurético. Acho que seria importante, porque a doente estava em hipocaliémia, não estava a tirar grande benefício da medicação, tinha adicionalmente, eu não referi, mas sintomas hipotensivos. E, portanto, propusemos à doente substituir o carbonato de cálcio por citrato de cálcio. Uma vez que o citrato de cálcio tem uma absorção independente do pH gástrico e, portanto, pusemos a hipótese de que a reversão da cirurgia bariátrica podia não ter sido completamente eficaz. No entanto, encontramos algumas dificuldades. Uma delas foi que, como sabem, o citrato de cálcio tem um conteúdo de cálcio elementar menor, portanto, para fazer doses equivalentes, a doente teria que fazer mais comprimidos por dia. Para além disso, o citrato de cálcio é vendido de uma forma não regulamentada, como um suplemento. De qualquer maneira, face a essas dificuldades, propusemos um regime terapêutico com 3 comprimidos, a tomar 4 vezes por dia, numa dose de 2.892 mg de cálcio elementar. No entanto, a doente recusou. Seguidamente, nas consultas seguintes, portanto, reajustamos a dose de levotiroxina, tentamos melhorar a suplementação de magnésio, substituímos o suplemento de vitamina D por calcifediol, paramos o diurético tiazídico e isso permitiu-nos parar também o suplemento de potássio. e propusemos à doente um esquema de carbonato de cálcio. Substituímos o comprimido de carbonato de cálcio de 250 por 150, de forma a que cada comprimido pudesse dar um bocadinho mais de cálcio elementar, e dividimos em dividimos em 4 administrações de 2 comprimidos e pedimos à doente para tomar com as refeições e que tivesse o cuidado de ter um intervalo de 2 horas entre o cálcio e a suplementação de ferro. Para além disso, subimos a dose do calcitriol, ainda assim a doente tem um cálcio sérico que está insuficiente, ele oscila entre 7,2 e 8,1. Portanto, volto a perguntar o que é que fariam então nesta altura. Portanto, a opção A podia ser... Pronto, era de facto o nosso desejo, mas ainda não temos disponível nenhum medicamento a não ser em utilização off-the-label. E, portanto, em relação às restantes opções, teríamos a hipótese de aumentar o calcitriol e o carbonato de cálcio, voltar a propor à doente a substituição do carbonato de cálcio pelo citrato, reiniciar o diurético tiazídico, iniciar um suplemento de enzimas pancreáticas que contivesse lipase e depois a associação de dois, o suplemento pancreático com lipase e substituir o carbonato de cálcio ou este suplemento aumentando as doses de calcitriol e carbonato de cálcio. E pronto, basicamente o que se fez foi propor à doente iniciar este suplemento de enzimas pancreáticas, portanto, pensando também que a reversão da cirurgia bariátrica não teria sido completamente eficaz, poderia melhorar a absorção da vitamina D e voltamos a propor a substituição do carbonato de cálcio por citrato. E, portanto, as mensagens que eu trazia é que a cirurgia bariátrica é eficaz a tratar a obesidade, mas altera profundamente a homeostasia do cálcio e da vitamina D, através de múltiplos mecanismos. Por um lado, diminui a ingesta dos doentes e isso favorece déficits nutricionais múltiplos, incluindo o de cálcio e vitamina D. Por outro lado, a acidez gástrica fica diminuída, o tempo de trânsito intestinal também fica diminuído e, nesta cirurgia em particular, há um bypass das zonas mais importantes para a absorção do cálcio, que é o duodénio e o júnio proximal. Para além disso, há uma redução, há uma exposição reduzida aos sais biliares e enzimas pancreáticas. E, portanto, é muito frequente na cirurgia bariátrica, mesmo sem um hipoparatiroidismo associado, haver hipocalcémia e normalmente esta hipocalcémia necessita de doses elevadas de cálcio e vitamina D, sendo que o cálcio deve ser preferencialmente substituído por citrato de cálcio. Casos casos refratários. Em casos refratários a esta intervenção, nós podemos socorrer de diuréticos e podemos socorrer de enzimas pancreáticas, mas a evidência sobre isto ainda é limitada. Por outro lado, também queríamos, deixo esta mensagem que a reversão da cirurgia bariátrica deve ser reservada só para casos muito graves de hipocalcémia resistente ao tratamento. Porque não há muita evidência também sobre isto, mas a reversão da cirurgia bariátrica tem uma taxa de sucesso variável e muitas vezes os síndromes metabólicos e mal absortivos persistem. Nos doentes com hipoparatiroidismo, como era o caso desta doente, realmente a utilização de terapêutica recombinante com paratormona e melhorar o cálcio, a homeostasia do cálcio e do fósforo, com a vantagem de que ia reduzir drasticamente a sobrecarga de medicação nesta doente e melhorar a qualidade de vida. Para além disso, queria deixar só uma última mensagem, que é, antes das cirurgias bariátricas, é fundamental haver uma avaliação endocrinológica e que, se houver alguma indicação de cirurgia da tiroide, ela seja realizada antes da intervenção bariátrica. E é só. Obrigada. Any help?
I just have the microphone, so I keep to comment on this case. So congratulations for both challenging cases. Your last sentence was very important regarding the indication for surgery, because in this case it's really a pity there was bariatric surgery and then there was an indication for thyroid surgery. Obviously not a very hard indication, and we also have written this down in the guideline to really be very cautious with the indication to avoid overtreatment of thyroid cancer. This is the case in Austria. We have many patients with hypo-PT. You look in the medical history, it was all benign. It was not a very hard indication. So I think one of the learnings for me is to be very cautious as your conclusion with thyroid surgery indications. One question that I have is you gave the calcitriol 3 times a day. So 3 times a day. Why do you do this? The calcitriol, you had 3 times a day that you give it, and we discussed this also in the guideline group. And by convention, usually many use it once a day or twice a day. Many say, okay, you can use it twice a day because the half-life is quite low in the blood, but the biological half-life is quite long. So from the data we have on calcitriol, it may be feasible to give it just once a day, although by convention most give it twice a day, but I don't see any need to give it twice a day. So 3 times daily. This was unusual for me. It's just a comment. I don't know whether you do this. And I think Neil already alluded on the calcium supplementation on the very high dose. So we would try to reduce this. But of course, this is a very special and challenging case. But congratulations, you saved the patient, obviously, with the resurgery. And yeah.
Thank you.
Can I ask, but in this case with malabsorption, maybe it is just like other people, or trying to give fractionally, it's better 3 times a day.
Maybe you're absolutely right.
I don't know, I'm just questioning.
Particular case, I was just making this point because this is very unusual. We would not give it twice a day, but maybe for this special case,
maybe more
these are
times
very
a day.
special circumstances, and this is our only expert opinions.
Okay.
So.
Thank you both for the input.
Just a little question.
I'll try to
How do you get the citrate, calcium citrate? Because here, I don't think, we used to had one, was I think the calcite or something like that, but not anymore. So how do you get it?
That's what I wrote there. One of the difficulties we had is that the calcium citrate is not regulated. So I asked the patient to go to a supplementation store, and I have to trust. And that's why also that was one of the problems when we proposed first time that change. That was one of the things that we alert the patient and could have make her refuse.
Anna, but you can try to ask to your hospital, or it is in private practice, because in the hospital you can try to ask to the hospital or
Pharmacy?
pharmacy,
Okay.
because it is a manipulate that they can do, or they can buy and give to the patient.
Okay.
It is possible, I think, in
Yeah.
I don't know if in Coimbra here.
No, but we have at least in Porto, I know of 2 pharmacies that do it.
Okay.
Yeah.
At
Yeah,
ambulatory pharmacies?
Yes.
Yes.
Ambulatory pharmacies,
Yes,
communitary
yes.
pharmacies.
They can do it.
Okay, perfect.
Or you can ask to the hospital, because there are some cases that they do that,
Okay.
and give for free to the patient.
Thank you so much.
Okay, so go on. Do you need?
I'm currently following a patient who has a surgical hypo-PT, and she has class 3 obesity. And we considered if she could do bariatric surgery, a sleeve. What's your opinion about that? Because the multidisciplinary team refused it. So what's your point of view?
And what's the indication for
She has class 3 obesity.
And did the patient try the pharmacological therapy first?
She cannot buy it, so.
Because for me it is the first option for this patient.
Okay.
But I don't like bariatric surgery in this
Yes,
patient.
we thought that a sleeve may be, may there's something. Of course, the low of
How is the control
acid.
of the patient?
She is taking around 5 to 6 pills of calcium a day, so it's not very good.
Because it will
very
getting
good.
worse. I think that will getting worse. You have to explain to the patient the risks.
Of course. Yes, she was
And
refused
wait
actually, but
for, I don't know if we will have participation in the future in Portugal, so we can wait for
hope so.
this. I don't, it is an idea. It is my opinion.
I agree.
the sleeve doesn't bypass the zone where calcium is more absorbed, but will have difficulties in reducing the acidity of the.
Elizabeth?
Yeah, maybe I missed it, but I wonder what would be your opinion if this patient asked for PTH replacement therapy?
My opinion?
Yeah, and maybe of Maria as well. I'm wondering.
No. I would be favorable in any question, in every question we pose. I refer, but in Portuguese, that probably it would be the best solution for the patient because it will help with the burden of pills and getting the control. She is not able to have with calcium and vitamin D, especially in this case that we don't have absorption. The conventional therapy is not. It has a barrier to get to the cells that need the effect.
I'm just curious, can you get PTH replacement therapy in Portugal? Is it reimbursed in some way?
We don't have. We only have PTH teriparatide. So we just, if we need to use it for this indication, it would be off the label. I don't know if you have any experience and how you would manage with the teriparatide case of. Yes.
Difficult.
Only, Miguel, you can share your experience because he has a patient, but with
So I do have a patient with refractory hypoparathyroidism. It's a post-surgical hypoparathyroidism, and she's under teriparatide, but with a continuous infusion pump. So we use an insulin pump, and we apply teriparatide on that, and she's using it continuously, trying to mimic the palo-peg teriparatide pharmacokinetics. And it's working well. We were able to reduce the calcium daily dose and calcitriol daily dose a lot. And she's stable for several years now with a teriparatide pump.
And it is well tolerated.
Yeah, she tolerates it well, very well. And she even got pregnant using the teriparatide pump. Yes, and we were able to discontinue during pregnancy, and then we had to put her back on the pump.
I guess I'm from Greece, so I guess we are in much fortunate condition because we have long-acting PTH analogs. But anyway, so we can go on. And we just, wrap up all the knowledge that we have from our distinguished speakers about the core treatment goals and practical describing tips and when to consider PTH replacement therapy. And then Dr. Churde will analyze us all the data that we have. And I can share with you some real-world data with PTH replacement therapy in our hospital in Greece. So again, repetition, knowledge through repetition, but just to make sure that when you leave this room, you don't want to hear about hypoparathyroidism again, okay? So it's to hormone deficiency. Why are we saying that and say it again and again? Just to see that it's the only endocrine deficiency, if you can think about it, that has not been properly replaced all these years. So we only replaced it by half through activated vitamin D, but otherwise it was not replaced. So this is the clinical presentation, and again, there are so many organ systems that are implicated, that are involved in the clinical presentation of hypoparathyroidism, and some of them may not be so abrupt, maybe subtle. So the clinician should actually ask specifically the patient of how he or she is feeling, if she has any kind of fatigue or anything else, or brain fog, because it's not like, are you feeling good? Yes, I'm feeling good, and it's enough. So we need to address this, to elaborate more in clinical symptomatology. And then is how to monitor from the revised guidelines. Let's get deeper into this. So the primary target, of course, is calcium. Calcium and symptomatology. The patient needs to be symptoms-free, and the patient needs to know what to expect from hypoparathyroidism. And the calcium level should be low or low normal, or again, something that is very comfortable for his daily life. And then comes the problem, because it is easy to say, just maintain the calcium levels there. But again, it's not so easy to do, and we've seen some really practical and difficult situations from our colleagues, and we see it's not that easy in the everyday clinical practice. So we use calcium, vitamin D, calcitriol. In Greece, we only have alpha-calcidol, and we use it in divided doses. But then again, we do have carbonate or carbon citrate, and it's really difficult to maintain calcium serum only with calcium. Always we need alpha-calcidol. And then again, as Veli and Alex in the very elegant presentation of Neil, we've seen that calcium is not that easy to be absorbed. We only can absorb 500 of milligrams per absorption per dose of elemental calcium, so that means a lot of pills during the day. And then the larger single doses exceed intestinal transport capacity, so it cannot be really effective if we need to increase calcium. And then we have the secondary treatment targets. We have hypercalciuria, hyperphosphatemia, hypomagnesemia, and 25-hydroxyvitamin D. We've talked a lot about hypercalciuria. So thiazide diuretics, it's something that we probably cannot avoid, but it's not the real solution. They come with many problems, and we have to keep an eye on our patient because of electrolyte disturbances. And as we discussed, we need high levels of hydrochlorothiazides just to correct calciuria or to maintain it in normal levels. And then again, there is volume depletion and hypotension. So it's something that can correct what we actually induce with calcium supplementation in a patient with not PTH, but it's not the real solution. And sometimes there is a risk for overcorrection and serum calcium fluctuations that can actually aggravate the quality of life of the patient. And then we have the hyperphosphatemia, and we easily say to our patient, avoid some of the food that contains high phosphate levels, but look at here, it's everywhere. And then if we do that, if we restrict phosphate, we can unintentionally reduce our balanced nutrition with lower protein intake and calcium intake and the overall diet quality. So again, this is not something that we can easily do it in the clinical practice. So hyperphosphatemia, we don't really have a very robust way to correct it. So we have to be really careful. And again, we know that high phosphate levels with high calcium or fluctuations of calcium can cause many other problems. So it is a difficult stuff to do during the everyday clinical practice. So what are the limitations of conventional therapy? There are a lot. Except for the pill burden, we actually require very close monitoring to accommodate changes in dietary calcium. And then we have the renal complications and ectopic calcifications that are very easy to be evolved if we are not careful enough. And then we don't have, in these guidelines, we mention a lot about quality of life, that this is really important for our patients. Mainly, most of our patients are young patients, and they will need to take this conventional therapy in long term. So it's important to quantify what that quality of life means. And then we have hardly burdensome treatment regimes with activated vitamin D multiple times daily or large doses of calcium supplements. So it's really a difficult situation that is going to be manageable. It's not that easy. So when to consider PTH replacement therapy, and this is what I would like to bridge with Dr. Chudi that will follow, is when treatment targets are not achieved despite repeated optimization of conventional therapy. And then again, if we want to be more specific, think about what happens to a patient that the impaired quality of life, that it is attributable to chronic hypoparathyroidism, cannot be improved, or he or she have a reduced kidney function, persistent hypercalciuria, or hyperphosphatemia, because as we've shown, it's not that easy to manage. So in the revised guidelines, we have this busy slide, but it's really, really easy to follow if we go through step by step, made by Dr. Louis and the whole group, that actually shows you how to treat patients that you decide that they need to be on PTH replacement therapy with TransCon PTH. So having said that, I think it's important to emphasize that patients need to be educated of their condition. This is a busy leaflet, but actually it incorporates all the relative information. Patient needs to know what is to expect when he or she is hypocalcemic or maybe hypercalcemic in the long term. So for the treating physician to be easier to qualify and to quantify what kind of issues needs to be addressed in the management. And then again, it's a rare disease that has a risk of hypercalcemic crisis, and this needs to be addressed as well. So I'm going to share with you some of our data in real-world experience. We have TransCon PTH, the real wrong PTH analog that is now available in Greece from June 2024. So we conducted this multi-center prospective cohort study in patients that were transitioned from conventional therapy or from PTH 124. In Greece, the TransCon PTH is completely reimbursed, 100%, but we need specific criteria. So this is the criteria that we have, and actually more or less the same with the international guidelines. If one of the following, this is what we would like to point, if the calcium levels remains low despite optimization of treatment, or you have renal complications, or phosphate remains persistently increased, then the patient is eligible for starting replacement therapy with long-acting parathyroid hormone. So what we wanted to see is the time to ability to fully discontinue activated vitamin D and calcium supplementation. Just to remind you, in most of the studies for real the RCTs with TransCon PTH, the independence from calcium and vitamin D allowed for calcium lower than 600 milligrams per day. So we wanted to see if no calcium and no vitamin D is given to the patient, if can actually have all this, can be really, hypoparathyroidism can be really controlled even if no activated vitamin D and calcium supplementation is on. And then we wanted to see the changes in biochemical parameters or how well this treatment was tolerated. So we have 92 patients with a mean duration of disease from 10 years and a mean follow-up duration for 6.5 months, and the range was from 2 to 14 months of treatment with pyrrolobecter. And as you can see, at the end of the study period, all the biochemical parameters were improved. Serum calcium, serum phosphate, serum magnesium was increased, GFR was decreased, calcium phosphate product, 24-hour urine calcium. So everything was really better at the end of the study period. And of course, the pill burden was significantly decreased. So around more than 50% of our patients in about 2 months were actually able to discontinue all calcium supplementation and all activated vitamin D with having stable doses of pyrrolobecter and no symptoms and complete biochemical control. And as you can see, the drug was really well tolerated. So that made us feel good because then we are becoming good doctors. The patient has a really decreased pill burden, feeling better, and all the biochemical parameters are better. And even for those that achieved independence and for those that did not achieve complete independence from calcium supplements and alpha calcidol, you can see that in the whole parameters tested, there was a significant improvement with the initiation of TransCon PTH. So that was real-world data. Our manuscript is under review for the time being, and we're wanting to share with you that within this first year that we are having PTH replacement therapy from long-acting PTH, because before that, we also had teriparatide off-label or PTH 124, but again, the efficacy was not the same because of the fact that it was not long-acting. The third way is to have a pump, but it's really troublesome, I believe, and I'm not sure if it's reimbursed, if the patient has to pay for himself for the pump or... Yeah. Okay. So, yeah, just to wrap up everything we said, that's what I wanted to tell you. If you have any questions, I will be glad to answer anything, or we can discuss about what is going on in Portugal, what is going on in Greece, and what things can be changed. Thank you. So you're convinced that you have to bring PTH analogs, right? Long-term PTH analogs. Okay. Yes, please. Yeah, thank you for this. Are you one of the reviewers? No. For that or no? Okay. You wouldn't say that anyway. Well, for the second question, no, we checked, couldn't find any predictor of what will go better or not. And actually, no, we didn't have any non-responders. We just have some people that need to be titrated more quickly to 21, 24, 27 micrograms. But most of our cohort were really well controlled with between doses of 21 and 24 micrograms. So, yeah.
Okay, thank you. What about the bone, the safety on bone? Do you have data until now?
No, we didn't have a washout period. If this is what you mean, we just started that just the next day with the 18 micrograms. But this has been done, I think, in the US cohort, and none of, if either with a washout period or not, it was not difference. So I'm not sure why to do this washout period, since what we really need to do is to have our patient feeling well and being well biochemically controlled.
Yes, but my question was regarding the safety on bone. Do you also safety on bone, the bones? Do you have any data? How are you looking at the possible bone mineral density, the bone markers? Also, regarding TBS, if you have some data regarding that?
Well, actually, we don't have, we only have baseline values, and no one of our patients had low BMD in the range of osteoporosis or severe osteopenia, but we don't have actually the second measurements after 1 year. So it's because most of them was in 6 or 7 months, but we are now going to collect this data. Well, for what we know, it can be decreased a little bit, but then again, it does not go to osteopenia or osteopenic or osteoporotic levels. That it just remained above 0. So that means that it's back to normal or something like normal for each patient.
Hi, again. I have a very specific question, is whether or not you have experience using this, the pilopac teriparatide in patients with autosomal dominant hypoparathyroidism, and if not, if that happens to happen in your clinical practice, would you try to use it? That is because of the theoretical risk of increasing the hypercalciuria due to the calcium sensor mutation, receptor mutation. So I wanted to hear about that.
It seems very reasonable to me. No, I don't have any experience for this, but it can be useful, I believe, might be, due to the persistent hypercalciuria in these patients, but no, I don't have any kind of experience.
But you know there's hope for ADH with the new drug, and that has been tested already, so yeah.
Caloret is also trying to test it in hypoparathyroidism as well for patients with
of course. So my question, we discussed it earlier, is on the target range of calcium on pilopac. So we made some comments on this and discussion in the guidelines. How do you handle this in clinical practice? Or to be specific, do you keep anyone on pilopac below the reference range, or do you take care that everyone is within the reference normal range for calcium? What's the difference for you as a clinician when you talk about target ranges, also with the patient?
Yeah. Well, actually, because it was not only in our center, we were 7 university centers, and the clinical practice, we've seen that most of the patients were between 8.4 to 9 milligrams per deciliter, so not in the low normal. But they are feeling good in this level. So I guess, yeah, we should try to stimulate whatever remains, even with the PTH replacement therapy maybe, although we don't need to be really, really strict with the calcium level since we don't have problems with hypercalciuria. But then again, it's something dynamic that we need to address. In our experience now that we have collected all this data, we didn't have many people sustained in the low normal. Most of them were above 8.5 milligrams per deciliter, but lower than 9. So this was our experience.
Just one simple question. In these patients, when you assess the recovery of the potential recovery of the parathyroid, endogenous parathyroid hormone, you spot it because you reduce progressively the dose
You
of
can
the
measure
medication?
PTAs because PTAs is still low.
Yes.
You cannot measure, you don't measure piloopectoral parathyroid, so
Okay.
you can still, or just see if something changes.
Okay.
But yeah, it will be more difficult than the conventional treatment because this is, most of the patients have really stable calcium levels. Maybe between the second and the third month we have some fluctuations, but then they were all stable. So it really works, and I'm not sure how to only from with biochemical measurements I will just check for any.
Okay. Thank you so much.
I want to be intentionally provocative relating to the last point. In the guideline, do you think we should have been more directive in the scenario of PTH replacement therapy? Because we've already identified that it's quite possible to have hypoparathyroidism with detectable PTH. On PTH replacement therapy, if we are adhered to our once a year checking whether endogenous function is returned, should we be saying that we should induce mild hypocalcemia to test whether they're endogenous? Again, I appreciate there's no answer, but I wonder
sure.
now whether the guideline might have gone there a little bit more actively.
Thank you.
Yeah, can you just rewrite the guideline while you're standing there, Maria?
Well, you know, speaking from experience now, not with no scientific data on my mind, but this range that we succeeded very easily with piloopectoral parathyroid was, and we measured that with the specific questionnaire, was really made a difference in the people's life. So I'm not sure how persistent we should be in keeping low calcium level or low normal just for the probability that it might go again and work. I don't think it's something that we can balance every time in a specific patient. Are we running out of time, I think? Okay? Yes, okay, thank you.